Um, welcome everyone to our care conference and this session around the care workforce well-being. I have the pleasure to chair the session today, and my name is Karla Zimpel-Leal. I'm an innovation fellow from the University of Sheffield in the UK. And I also work alongside the Sustainable Care Program. I'm looking at emerging models of home care and also workforce skills development. So I'm very excited to hear all the presentations. We have 3 presenters and a discussant. Just to recap, I'll introduce each presenter today, and then they'll have up to 15 minutes to present. And when you have a minute left, I'll let you know. And at the end of all presentations, I'll invite the discussant to introduce her comments. I also encourage all of you to keep your notes and questions, as we're going to have a Q&A session at the very end. So without further ado, our first presenter is Karolina Gerlich. She is the Executive Director from the Care Workers Charity. And Karolina has extensive knowledge and experience with the care workforce. She has been a very key figure in the UK in terms of research and policy, and also campaigning to ensure that the care workers' voices are heard. So her presentation today is around the well-being of care workers in the UK. So Karolina, back to you.
Thank you very much, Karla. Hello, everybody. Thank you very much for attending the conference today. And I'm looking forward to giving you some information around the well-being of the social care workforce. If I could have my slides, please. Next slide, please. Can't really expect care workers to deliver high quality of care without making sure that we look after the workforce properly. In recent years, according to research done by Mind, 1 in 4 people will experience mental health problem every year. And obviously, we have seen research done recently around mental health around COVID, and we know that these issues have become even more acute. In 2019, the Care Workers Charity, we ran a report research around key issues affecting care workers. 42% of those told us that they expressed stress and anxiety regularly as a result of their work, and that mental health well-being of care teams was the biggest staffing concern for managers. Talking to care workers and managers in the last few months, we are seeing very high levels of burnout, and people are really struggling to be able to continue working. Additional deaths and bereavement in the workplaces, additional responsibilities around COVID, all of these issues are really compounding and adding up to a huge mental health strain. Next slide, please. So, in terms of what contributes to the well-being of a care worker, there are many different factors. Some of the most important ones are sickness and absence, which rates have doubled since before the pandemic, according to Skills for Care. Then we are seeing evidence that there will be increased burnout and mental illness count around COVID, which we're already seeing, and especially post-COVID around PTSD. Workers in social care by occupation had some of the highest rates of mortality in the first wave of COVID, according to the ONS, and very unfortunately, we lost care workers in there. As a charity, we have been supporting people with grants around funeral costs, because for somebody on very low pay, even covering those, it's very difficult. In terms of demographics of care workers, they are more likely to contract and die from the virus. Some of the issues around that were because of provision or the lack of provision of PPE, especially around the first wave to social care and discharges from hospitals into care settings without COVID testing. Care workers needing to isolate could find themselves with the financial difficulty. Obviously, a lot of care workers are not getting full sick pay, and that's been something, again, that we've been trying to support. And we've had many care workers reporting around stress because of financial difficulties. Like I mentioned, many care workers have experienced higher numbers and higher levels of loss and bereavement. Many care workers are used to every now and then losing somebody that they work with. Obviously, that depends on the type of service they work with, more so in a hospice than you do in day centres. But COVID has brought those numbers very, very high. Care workers have struggled with having to go through bereavement whilst continuing to work, and many have experienced multiple bereavements in short spaces of time. Care workers have been forced to decide between consequences of isolating, and those are financial consequences for them and their families, and remaining at work and potentially putting people at risk. Again, that was especially difficult during the first wave, but even now some care workers are struggling with that. And then general very big anxiety around delivering care, potentially passing on the virus. There have been care workers isolating themselves completely from their families, only going to work and back, living in hotels, moving into care homes, living away from their families, sending children to grandparents, for example. So a huge level of responsibility that really weighs down on their mental health well-being. Next slide, please. At the Care Workers Charity, we are really trying to champion well-being of care workers. Like I mentioned before, it's extremely important that we look after the workforce, and then the workforce can look after people who need care. At the moment, we do that through routes of financial support, through our financial grants in the COVID and crisis streams, mental health support, and just a couple of weeks ago, we opened a new grant stream where people are able to apply for up to 10 hours of one-to-one therapy. And we're signposting to appropriate organizations where we can't help directly, but we know other help is available. For a care worker, there are many different parts, not just for a care worker, for any of us, many different parts of our personal working life that contribute to our well-being. And we understand that if a care worker is struggling financially, they will find it very difficult to perform as well as they would like to at work, because of ongoing worry about putting food on the table for the children or paying basic bills. Next slide, please.
As a healthcare assistant, our role is very, very important because we are first point of service. But if you have so much on your mind and you're going through so much at home, you don't have food to give to your kids, you have no heater, you have no lights, you stress out, you cannot go to work and be focused to deliver your 100%. I was really in a very, very bad place, me and my son. This last couple of years, I had to vacate my private rental house that I was renting, and then I had to apply for council, and from there they gave me temporary accommodation, which is where we are living now. I couldn't afford anything. I don't have nothing because I was off from work for 4 or 5 months, and then that is when Tom helped me to apply for Care Workers Charity for me, and then I got the support that you people helped me with. So I'm really appealing to the general public to help the Care Workers Charity so that they can help people, because there are so many people who are struggling out there. Thank you very much, and thank you so much again. Bye, take care.
Next slide, please. This was one of our applicants. Like she mentioned, she was struggling in temporary accommodation with her child. And as a charity, we did our best to support her to help her secure better accommodation and make sure that she could continue working in social care, because that's definitely an important part of what we do. We're trying to support care workers and their well-being in a way that helps them stay helping other people. In terms of our impact in grants last year around supporting care workers, we paid out almost £2 million to over 2,800 care workers around COVID issues. And like I mentioned, well-being, financial around COVID has been difficult. Care workers have had to self-isolate, shield, often on no or only statutory sick pay. And we've tried our best to top up those payments so they're able to have at least the basics in their lives. Then crisis grants, which apply to different areas of life that contribute to well-being. Simple things like broken white goods, car maintenance, going to things like escaping domestic violence, or having to cover some debts. And then, very unfortunately, we've had to support 39 people with funeral costs, and that goes both ways for care workers whose family members have passed away, and also for families of care workers who have passed away. And we really try to support people in that bereavement. And with mental health support, like I mentioned, we have just opened applications where we will try our best to support care workers' mental health. Next slide, please. In terms of the wellbeing agenda, as we see it for care workers, the most important thing is that well-being of the social care workforce is seen as a priority to care operators, managers, and to the government. We need to make sure that the workforce is strong, resilient, well looked after, to be able to deliver good quality of care. We are worried that ongoing effects of COVID-19, especially with how long it has lasted, could bring social care to a breaking point. That we are hearing from many managers and care workers that they are really struggling to continue working, and ongoing additional pressures are pushing them past the point where they can work. The sector really must utilize the positive media coverage to inform policy. We need to lobby to the media to really focus more on positive stories in social care. Negative media coverage was really unhelpful, mainly to the morale of the social care workforce. There are people who are going out every day, doing their best, sacrificing many things in their personal lives. And when they get home at the end of the day, all they hear is negative media about what they do. And that's a very unfair approach, and it's really going to affect, and it is already affecting people's mental health. And what we need to be doing more is championing sector-wide reform that is appropriate in the way it supports an evolving workforce, professionalizes the workforce, supports training and development, and acknowledges the workforce as high-skilled, essential, and contributing hugely to the economy and the society. Next slide, please. That's it for me. I hope that gives you a better understanding of issues around well-being of social care workforce, and that will help you get on board more with supporting the agenda of improving the well-being of social care workers. Thank you.
That was great. Thank you very much, Karolina. If anything, a little bit difficult to hear, especially that video was a bit upsetting, but very nice. I'm looking forward to some discussion at the end. I will now introduce our next presenter, which is Lina Van Aerschot. Forgive me, Lina, if I mispronounced your surname. She's a postdoc researcher from the Center of Excellence in Research on Aging and Care in Finland. And her presentation will be on the psycho-psychological burden, what makes Nordic care workers in old age care to consider leaving their work. Over to you, Lina.
Thank you. Please, you can put on the presentation. So, hello everyone. I'm presenting a paper which is work done by me, my colleague Jiby, Mathew, Puthenparambil, Antero, Olakivi, and experiencing burden almost always. And we are examining the reasons for care workers' intentions to leave their work in Nordic countries. Next slide, please. So, some words for the background. So the shortage of care workers and the high turnover rates in this field of work are quite well-known facts. The care service sector struggles with shortage of trained personnel and of also difficulties recruiting enough workers to meet the growing needs of older people and aging population. And not only these recruiting problems, but also the high turnover rates, so that keeping the personnel is an urgent challenge. And the reasons, according to literature, for high staff turnover rates are related to stress and burden that is experienced by care workers. Next slide, please. In the Nordic countries, care is still a public service, but in an increasing amount, it is also provided by private companies. So the public authorities in the Nordic countries are responsible for the long-term care system, but to a different extent in all these 4 countries, the services are also provided by for-profit companies, and this wasn't the case, let's say, 20 years ago, when the care services were almost completely or only provided by the public sector. But at the moment in Sweden and Finland, the sort of marketization of care services has been a bit more large than in Denmark and especially Norway, where the services, or where the public sector is still largely producing and providing services. Anyway, the rationalities of new public management have been introduced also on the public sector. So the aim is to make the organizations as cost effective as possible, and so there is strict time and task management and sort of customization of care work. And then this has resulted in care workers feeling that it is difficult to provide good quality care because the work is overly task-oriented and time-restrained. Next slide, please. And our research task or research questions are the living intentions in care for older people in Denmark, Finland, Norway, and Sweden. So these are the 4 Nordic countries, Iceland excluded. And we look at the work-related factors such as autonomy, support from supervisor, time pressure, burden, and then also background factors like age, education, working sector, and type of work contract. And as I already said, living intentions are largely explained by stress and time pressure, work overload, lack of support. But what is a bit different with our data is that we have the chance to also consider aspects related to work content, such as like work tasks, like amount of documentation, workers' possibilities to affect the daily planning of work, and whether they find their work tasks interesting or meaningful, and things like experiencing threats of violence or even violence. Next slide, please. And as data, we use a survey. It's called Nordic survey, and it has been carried out in these 4 countries in 2015, and we have a bit less than 4,000 responses in the entire data. It is a random sample survey, and the respondents are from the membership list, or they have been contacted through the membership lists of care workers' unions. And in the Nordic countries, the workers are highly unionized, so even more than 90% might be members of the unions. And response rates are between 52 and 59, and the respondents are care workers employed in home care and residential care services, so home helpers, assistant nurses, care aides, nurses' aides, and practical nurses, but not registered nurses. Next slide, please. And we have examined the question, or our main question, which we base our study on, is: have you seriously considered leaving your current job during the last year? And the respondents could choose either yes or no. And we have used SPSS to analyze the data. We've done cross tabulations with chi-square tests, and then we used binary logistic regression analysis to see the sort of explanatory power of dependent and independent variables. Next slide, please. Yes, so between 1/3 and half of care workers consider leaving, according to our survey data. So Norway has the lowest share of care workers who have considered leaving. it's 34%, and Finland is there the second lowest rate, 38, and then Denmark 43, and Sweden has the highest share. Next slide, please. And first, we have a look at the background variables. So among those respondents who stated that they have considered, who answered yes to the question that they have considered leaving their current job, younger age was more common, especially in Sweden and Finland. And in Finland, the sort of profile of those who had considered leaving were that they were often under 30 years, or more often under 30 than 60 or above, and they had at least 2 years of professional education, so they were mainly practical nurses, educated practical nurses, and they worked on the private sector. In Norway then, on the contrary, the older care workers had more often said that yes, they have considered leaving their work. Then there was no statistical difference on, like, it wasn't statistically significant whether the respondents work in residential care or home care. So the sector did not play a role, or statistically, and whether they had temporary or permanent employment contracts, which was quite surprising to us also. Next, please. So this is, you don't have to try and grasp the whole table. It's just quickly to show you that the age, education, and employment sector are marked with the stars, so they are statistically significant differences between the groups, and then those that I've marked with red are the sort of differences that caught our interests, but I already explained them to you almost. So, but anyway, this was just to show you the idea. Next slide, please. And then other explaining variables and with differences between the countries. So Norway kind of stands out positively. If you remember, they had the lowest share of care workers with leaving intentions, and also the Norwegian care workers did not so strongly agree that their work includes too much documentation, and they did not feel quite inadequate because the care receivers would not receive all the help they need. So this was less common in Norway than in the other Nordic countries. And Sweden then had the highest share of care workers with leaving intentions, and they experienced burden almost always, and they stated that they do not receive support from their immediate supervisors. And Finland had the sort of worst situation in the sense that the care workers with leaving intentions stated they had most common, or more common than in the other countries, these negative, or they stated these negative aspects of their work. So they stated they cannot affect the daily planning of their work, that their work tasks are not always interesting and meaningful. They experienced threat of violence, and they were also worried that salary is not enough to cover their living expenses. So in this sense, Finland was sort of black sheep in this group, if you can say so. In English, I don't know. Anyway, in Denmark, the care workers with leaving intentions stated most often, or more often than in the other countries, that they have no time to do tasks that are planned for a care recipient. Next slide, please. So when we controlled for all these variables, so these are the results of the logistic regression analysis, the psycho-physical burden was, or turned out to be, the strongest predictor for leaving intentions. So the highest odds for leaving intentions was among those who often stated that they often experience work-related psychophysical burden. And in addition, not getting support from immediate superiors and not finding work tasks interesting or meaningful predicted leaving intentions. And then younger age groups are more likely to consider leaving than those who are 60 or over, except in Norway. And then care workers who work in the private sector considered leaving more often than those who work in the public sector, also except in Norway, where the private sector is very small, as I mentioned earlier. Next slide, please. Then some conclusions. There were some differences between these 4 countries, but the strongest predictors for leaving intentions were similar in all these countries. And the most important predictors for intentions to leave are consistent with findings in already existing literature. So they are actually factors which are related to organizational and management problems. So in a nutshell, one could say that the care workers have too much to do with too little resources, and they feel that they have to spend time for tasks that are unimportant or less important and not related to the essential aspects of care. And it seems that in elderly care, the intentions to leave are related to this vicious circle created by the demand for cost effectiveness and the inadequate staffing. So in this sense, the sort of principles that have been implemented in the public care service sector have also negatively affected the working conditions of care workers. And next slide, please, which is thank you. And here you have my email and a winter picture from Finland. So please contact me in case you have anything to ask.
Wonderful. Thank you very much, Lina. That was a great presentation and also very close to some of the findings from my own research. So very interesting. We have our next presenter, which is John Woolham. He is a senior research fellow from the Health and Social Care Workforce Research Unit at King's College London, and he will be talking about the employment conditions of social care personal assistants in England. John, over to you.
Thank you very much. Can I have the first slide, please? Well, thank you for inviting me. The previous 2 presentations have been talking about offering a broad assessment of the kind of well-being of care staff and the problems that the care industry faces across Europe, really. The presentation I'm going to give is focusing on one aspect of that, social care personal assistants. I think they offer an alternative model to orthodox care work, but there are concerns that which I'll talk about, that the employment conditions that they experience will impede their growth and the development of this sector of the care workforce. Next slide, please. Thank you. Just very briefly, there's very little known about social care personal assistants in the UK. There are a few studies around, principally Tom Shakespeare's work and some reports that have been conducted by the English Skills for Care organisation. So our study was really trying to map out, what personal assistants did, the employment conditions they faced, and so on and so forth. Our sample was geographically widespread. And our criteria for recruiting people to the research were that they were either directly employed by the person with care or support needs, or they were self-employed. I should have said really earlier that the unique characteristic of social care personal assistants is the direct employment relationship. Anyway, the research that we carried out, we've carried out a number of 2 different studies. Mostly, I'm going to base this presentation on the first, which was carried out in 2016. And And that involved interviews with 105 social care personal assistants and 26 people we describe as key informants. They were people who were, had a non-pecuniary interest in personal assistance. So centres for independent living, user-led organisations, etc., etc. But the first thing to say is that PAs were extremely hard to recruit to the study. So our sample is opportunistic as well as diverse. We thought originally that it would be easy to recruit from local authorities, but of course local authorities have very little to do with social care personal assistance. I'll say more about that at the end of the presentation. So we had to go to third sector organisations and user-led organisations to recruit. Next slide, please. Thank you. So who are they and what are they? They're a small but very stable part of the social care workforce. The Skills for Care organisation think that there are between 131,000 and 143,000 PA jobs, which is about 8% of the UK workforce at the moment, and that's been fairly constant for the last few years. They're paid for either privately or through social care direct payments, or through personal health budgets, which have more recently been introduced. And they do offer fairly unique opportunities for relationship-based care and support, which really is the holy grail of care work, I think. Our sample consisted of mostly female, mostly white. The mean age of the workforce was 45 years of age. Most had previous care experience, and there were, as I said earlier, the criteria for recruitment reflected the fact that people were either directly employed or self-employed. In terms of comparisons with the social care workforce as a whole, there's very little difference. Slightly fewer Black and minority ethnic people in our sample, and slightly fewer men, but otherwise very similar. Next slide, please. So this next slide and the next part of the slide, please. Thank you. The next slide really is just describing from three different perspectives what people see as good features of PAs. From the employer's perspective, they're very flexible workers. They will do what the employer wants them to do, and the employers have a great deal of freedom to train them in the way that they want. They offer continuity, so the individual is receiving the same care or support from the same people, and that confers an opportunity to build up a close working relationship with their PA and the PA with them. And the role is very flexible. It's very fluid and plastic, and it can offer either an enabling role where the individual is sort of really an extension of the physical being of the physical extension of the someone with disabilities, or it can be much more of a companionship focus as required. Next slide, please, or next part of the slide. Thank you. From the PA's perspective, what we found was that people were experiencing much higher job satisfaction levels than are reported in the care industry as a whole. We think that this is one of the reasons for this, is that there was much more time to focus on the person and not just the tasks and the time. And they, as I've said, they do offer a genuine opportunity to provide person-centered, relationship-based care. The fact that people are working closely on a daily basis with their employer means that they find out much more about how that person wishes to be cared for, but in the manner, not just the tasks, but the way in which the tasks are carried out, than is possible with other forms of care arrangement in the UK. Next slide, please. Thank you. And lastly, from a policy perspective, the English or UK policy direction is towards conferring additional responsibility on people with disabled and older people. The intention is that this will confer choice and control. There is a degree of role ambiguity, which is interesting as well. I'm not going to go here, but it's an interesting point. As I said, on the one hand, the role could consist really of being a physical extension of a disabled person's body, so almost invisible, acting as a cipher, or it can alternatively be a form of relationship-based care. The two really offer an interesting ideological contrast and contradiction, which, as I say, I'm not going to go into here, but it's an interesting issue. I'm going to move on now and talk about employment conditions per se. Can we have the next slide, please? Thank you. So here are a few snapshots of what we found from the interviews. First of all, employment conditions. We contracts. We found that almost a quarter of our PAs didn't have a contract, and 20% of those who did said that they had a contract from some but not all of their employers, because many had several different employers. And those that did have contracts frequently felt that they were either out of date or very vague. Next slide, please. Pensions. Now, the entitlement to a pension is really based on a calculation based on hours and earnings. And now, the average number of employers PAs had in our study was 3.2, and their combined separate hours and earnings from each employment didn't meet qualifying thresholds for pension enrolment. So that was a problem. But we've also found that 43% who should have been automatically enrolled were not. And overall, only 17% of directly employed PAs were in an occupational pension. And on the in relation to sick pay, eligibility for sick pay is that the individual has to be sick for more than 4 consecutive days and be paid more than £113 a week. And they need to tell their employer within 7 working days. And what we found was that 69% of PAs' earnings exceeded the threshold for sick pay, but of that group, 19% said that they would get it. 69% said it wasn't available, and 13% didn't know. Next slide, please. Thank you. National insurance next. I mean, this is, as people will know, a payment deducted from wages that confers eligibility to other state benefits, including pensions. What we found was that 27% of PAs either didn't, well, they either weren't paying national insurance or they didn't know if this was being paid on their behalf. And amongst directly employed PAs, 86% who should have been contributing were, but 14% were not. And on the in relation to overtime, 43% of people said they often or sometimes did unpaid overtime. Generally, it wasn't a lot. It was, maybe half an hour at the end of a shift or something like that, but it would add up. Mostly this was unpaid. Most PAs were employed on a flat rate contract, which meant that their rate of pay was the same regardless of the time of day or the day of the week. So holiday pay. In the UK, most full-time employees are entitled to statutory annual leave of 28 days a year. But 38% of PAs said no holiday pay was available, and instead they were asked to take time off but as unpaid leave. And payment for cancelled visits. Most PAs didn't work fixed hours; they worked the hours that suited their employer. So very much a 0 hours contract arrangement. And 37%, just over a third, said that they wouldn't normally be paid if an employer cancelled a visit, and 8% didn't know if they would be paid. So next slide, please. Penultimate slide, really. There was a very high tolerance of bad behaviour amongst PAs of their employers, and Although disputes were rare, they did occur, and occasionally they had really catastrophic consequences for the PA. But there were underlying reasons for this, which were related to not maintaining boundaries between work and non-work, and the lack of clarity about tasks and how to complete them. The poorly worded contracts that I referred to earlier were one contributing factor, but the other problem there is that the vague contracts also enable the employer to direct the PA to work in a more flexible way. So there's a contradiction there somewhere. And in relation to training, PAs valued training greatly and wanted to develop their skills. There were some impediments to this from employers who didn't necessarily want their PA to be trained externally. They wanted to mold them into the employer that they wanted, rather than, as they saw it, picking up different approaches to providing care and support. But PAs said that sometimes they felt ill-equipped to carry out some of the tasks that employers wished them to do, and wanted external training. And the funding of training was problematic because the direct payments were not. There was no ring fencing for training, unlike for personal health funded employers where it was. And then if we go on to the last slide, please. Just very quickly, just to summarise, what we found was very high levels of job satisfaction from PAs, demonstrable opportunities to develop person-centred relationship-based care and support, but large proportions of PAs receiving neither statutory employment rights or protections, and enjoying poor and precarious working conditions. Just to sort of conclude, we found that there was very, very little, virtually no support for PAs in the event of a dispute. They were non-unionised. They had no professional association to represent them. There was some online information available to them about employment in the way of employment advice, but most of it wasn't known to them. There were no opportunities for them to network with other PAs. They're not inspected, and they're an unregulated segment of the workforce. I think one of the very few that are not regulated at all. And that creates risks to both parties of exploitation. Disclosure and barring checks weren't always carried out by employers. Now the question really, which is a moot point, is how the conditions of employment of PAs can be improved without destroying those aspects of the PA-employer relationship, which both parties value so very highly. And that's, I think, my last slide, apart from some references. Thank you very much.
Thank you very much, John. That was very insightful and a different view about PAs, which is similar as well to my findings. I'd like to invite our discussant for some of her remarks. We have Amy Horton, who is a lecturer in economic geography from University College London. Amy, would you like to start us off with some of your comments? That would be great.
Yes, thank you, Karla, and thank you to all of the presenters for your incisive talks there. I really learnt a lot and enjoyed them. Karolina, it was great to hear about the Care Workers Charity survey results from before the pandemic, as well as the individual experience of Mathew and using your support, and the work that you and your team have been doing to support care workers over the last year as well. Lina, it was great to see how the union membership lists allowed you to access a large number of care workers across those different Nordic countries and produce the large-scale cross-country survey, which identified some troubling commonalities and interesting differences that we can discuss. And John, you presented some significant findings on the issues of casualisation that have affected personal assistance, but also the benefits of these arrangements. So I've got a few different kind of themes and questions that I want to pick up on, and which will hopefully generate some good discussion after this. So first, I wanted to reflect on the slightly different focus of each of your presentations, and then perhaps invite you to comment on the extent to which these issues relating to well-being overlap or differ. So Karolina focused on mental well-being and mental health, and particularly the stress and anxiety that can undermine these, which were frequently experienced by care workers even before the pandemic. And as you noted, pre-existing mental illness is associated with low pay. Lina and her colleagues examined the reasons for a range of frontline care workers giving serious consideration to leaving their jobs, and confirmed that issues with workload, meaningful work, and management support can undermine the retention of care workers and create that vicious circle of staff shortages. John, with his co-authors, focused on job satisfaction, finding that it's high among personal assistants, thanks to the care being more person-centred, and among their interviewees, at least, in spite of some of those issues with employment rights and conditions. So I think there we see some kind of connections to Lina's work, where whether people on temporary or permanent contracts wasn't significant in their intention to leave the job. So while those conditions and the lack of awareness of rights are concerning, I think these presentations both show the importance of being able to offer person-centred care, and that supports interpretations of well-being as being kind of relational and collective, perhaps more so, or at least equally so, to material and individual. And I think that echoes work by the Joseph Rowntree Foundation back in 2014, which found that although decent pay was important, other aspects of valuing and supporting care workers were also critical to their experience and to their quality of care, both within individual organisations, but more broadly across society as well. So how do we combat that kind of low status of care work and the negative perceptions that Karolina discussed? Looking at the programme for the conference as a whole, I see a number of other speakers are exploring the kind of different meanings of well-being for different groups of carers. So, for example, Shireen Hussain is talking about migrant live-in carers and their well-being. So my first question for the panel is then, to what extent are we talking about the same thing in our discussions here of well-being? Are there important dimensions of care workers' well-being that we haven't considered here, or that you think haven't been adequately researched more generally? How representative do you think the specific groups of care workers that your findings relate to are, and what differences might we expect to find among those care workers who weren't included? So Lina, for example, you'd mentioned that the rates of unionisation in the countries where you conducted your survey are very high, but obviously the response rate was just over half. So my second theme that I wanted to develop a bit was a kind of thinking more about how the ongoing changes relating to the pandemic are likely to affect care worker well-being in the kind of short to medium term, and perhaps more lastingly as well. So, we've talked about the ways in which working through the pandemic has harmed the well-being of care workers, and clearly dealing with the health and social impacts of COVID on people receiving care services has been extremely difficult, as well as the risks to care workers' own health and their families, while informal support networks haven't been able to operate as normal. So Karolina discussed the impacts in terms of burnout and mental illness that your organisation has been seeing. So I'd invite the panel to expand on these issues in terms of what COVID has meant for care workers' working patterns and workload, their earnings and their intentions to stay in their jobs. Of course, different stakeholders have taken various steps to try and mitigate some of these impacts, for example, by providing additional funding which is intended to cover sick pay, or offering bonuses to care workers in some contexts. I'd be interested to hear from the panel what you think are the most important interventions that have occurred recently and that could be made in the coming months to support the well-being of care workers. And here it'd be great to think across different scales of the care sector, so from individual workplaces to management and policymakers. Among commissioners, providers, and other stakeholders, there's been a lot of discussion about how the pandemic might be causing lasting changes to the form of care services. So, for example, will we see a shift away from residential care to greater home care and perhaps live-in care as well? Within care homes, there's efforts to create smaller scale household style units, partly for the reasons of infection control. Can we expect to see investors moving away from care homes to less acute and risky settings that might also be more profitable, such as retirement communities? So to sum up that set of questions, what changes in the form of care services do you expect to see as a result of the pandemic? And what might the implications be for the well-being of care workers? So next, I'd like to invite the panel to pool their expertise on how to address the problems that have been raised. So personally, I'm particularly interested in the connections between, on the one hand, how care is funded, owned, and managed, and on the other hand, how those factors relate to working conditions, the built environment of care homes, and the quality of care. Now, of course, this is a complex picture, that relationship between ownership and care quality and job quality. As Lina noted in her presentation, there's issues across the private and public sector. But just to say, some of my research has examined these issues in terms of financialization of care homes. So the ways in which investment funds restructure care companies to maximize returns to investors, both the intermediaries like private equity funds themselves and the ultimate investors whose capital they're managing. So those changes can involve extracting funding from care companies that could otherwise go to staff, facilities and services. It can also put care companies at greater risk of collapse through over-indebtedness, excessive rent bills and declining care quality. So this issue of financialization is not just about the redistribution of funds, but also a reorientation of care providers towards marketing and towards investors. Even individuals paying high care fees for a luxury experience might not be offered such good quality care or the most appropriate environments where these financial imperatives have come to dominate. So debt financing plays a key role in those kind of business models and has been building up in different forms during the pandemic. And this system, this model also pushes financial pressure onto care workers as they face lower pay and benefits. So picking up on that issue of debt, I wanted to ask Karolina if you could comment on the extent to which the care workers that you work with through the Care Workers Charity have been struggling with debt and what that means for their well-being. As a kind of flip side to this, my other question is, how can the management of care reflect the interests of those using the services and the frontline staff delivering them? So one alternative business model is the cooperative, and there have been experiments with those across the care sector, more in home care than care homes, given the capital costs in that part of the sector. So Karolina, back to you again. I know you're on the board of a home care cooperative, and it would be great to hear more about what you think that model offers in terms of greater autonomy for workers and service users, and other benefits that can contribute to their well-being, as well as the challenges. Lina, the issues that you mentioned about kind of care services being overly focused on time and task are very familiar to those of us working in England as well. So I wondered if you could talk about the extent to which alternative approaches that have been kind of put forward and to some extent rolled out here have been adopted in the countries where you've conducted your research. So, for example, we've seen efforts to reorient commissioning around outcomes and to ensure that care services are designed and managed through co-production involving relevant stakeholders. So in the Nordic countries where you've worked, are we also seeing those same kind of solutions being put forward to some of those problems with the kind of dominant care culture and commissioning practices that you mentioned? Turning to John and your points about the absence of inspection and organisation as ways of upholding the labour rights of personal assistants. So this made me think of reforms that took place a couple of decades ago, almost, in California, where after a sustained organising effort by a union, a public authority was set up to act as the employer of record for home care workers. And the role of the authority was to bargain with the trade union around employment terms and conditions, to provide training, and to run a registry to match workers with prospective clients. So these arrangements help to strengthen the rights of care workers and also to ensure that those employing them weren't left on their own to fill gaps in their provision if a care worker fell ill, for example. So I'd be interested in your thoughts on that model or on other ways to answer your question about how can conditions be improved without destroying those aspects of the PA-employer relationship that both parties value so highly. And finally, I'd like to pick up on the theme of how to change things for the better. So I'd be interested to hear from each of our presenters about how their research has been received by stakeholders who have the power to respond and to change things. Of course, we know that there are long-standing fundamental issues that are detrimental to care worker well-being that continue despite repeated policy commissions, extensive research, and advocacy by various organisations in the sector. The current system in England and slightly differently in lots of other countries offers care on the cheap, with some investors able to extract profits from the sector. So how do we build pressure for profound change to the ways in which care is funded and run to promote good services and care worker well-being? One approach that I've studied is the effort in the US to create a movement called Caring Across Generations, which involves diverse stakeholders and recognises that we're all dependent on care of different forms throughout our lives. So the organisers of this movement have been kind of bringing together concern for childcare and elder care as both devalued, feminised and racialised forms of work. They've argued that one of the reasons why there isn't greater pressure for change is a widespread aversion to facing care because of the negative associations with abuse, ill health, and so on that we've mentioned already. And instead, they argue that we need to promote more accurate, rounded, and positive representations of care, kind of just telling some of the stories about what care enables people to do, the relationships that can be formed, and so on. And I think here in the UK, it's something that the Social Care Future Group has also been working to do. So that this perhaps resonates with Karolina's comment about the sector needing to use recent positive coverage to inform policy. So I'd love to hear more from Karolina about kind of how we can build on that, and from the other panelists as well about kind of the potential for changing the ways that people think about care and building that greater pressure for positive reforms. I think perhaps some of this resonates with wider thinking or rethinking of cost-benefit analysis and a kind of narrow focus on productivity or growth that we've seen with some of the policy debate around levelling up and revisions to the Treasury's Green Book. So kind of supplementing GDP with wellbeing data and kind of a more holistic approaches to economics in general. So the final question for the panel is about the kind of politics of change for improving care workers' well-being. So do you see this approach that I've briefly outlined of organising to rework popular perceptions of care as useful? Or what else is needed to ensure that we can move away from a position in which care workers are often so undervalued? So thank you all for your talks, and I look forward to the discussion. I'll hand back to
Thank you. Thank you very much, Amy. That was a great summary and lots of positive points. We'll take a few hours to go through all of them. No, it's great. I was just wondering if I can invite back all the presenters so we can start to have a chat. Karolina, do you want to address some of those points? Do you want Amy to just reiterate some of the questions again for you, or you want to go for it?
I'm happy to address some of the questions. I'll be able to capture them all. I don't want to take up too much time. I think firstly on the point of what you said, some research and opinions were saying about the workforce being very gendered and issues around that, and that we don't put value on social care. And obviously that also feeds into the fact that there are a lot of care workers who are migrants, and obviously migrant workforce is also often perceived as less valuable. So we are currently doing some research at the Care Workers Charity around history of care workers and social media perceptions of care work. And some things that are coming through are definitely around how the sector is gendered, how the work that care workers do now used to be done by women in unpaid capacity before women were working as much as they are now, where women used to be stay-at-home mums in majority, and how the transition from it being unpaid work being done by wives, mothers, daughters hasn't really come with recognition of the effort. It is still this unseen work that is often perceived as not being valuable enough, not important enough, and most definitely not skilled enough. And that whole attitude and history behind it definitely feeds very strongly into general public perception of social care work, of the government policy around social care, because the issues that paid workforce is facing are also some of the issues that unpaid carers, of which there are millions, are facing as well. And altogether we have a huge number of people whose huge work and contribution is being terribly undervalued and underappreciated. So there is a lot of work to be done to address and educate the public, the government, the policymakers around the importance of care work. I think a lot of people still don't understand enough what care work is. The general perception seems to be stuck at the level of providing personal care, when we all know that social care is so much more than personal care. And don't get me wrong, personal care is extremely important. For many people, that's something that when they receive help with, they can continue with the rest of the day. They can remain independent for so much longer in their lives. But we can not only perceive and fund social care as personal care. We have to look at, and I suppose that addresses one of your other questions, what needs to be done to improve things. And that is a very wide-ranging, robust, and very strong reform of social care. The sector as is right now, first of all, lacks of proper funding. And even if we're talking about private companies delivering care, there are historical reasons why that happened. But I don't think people who run care businesses, people who deliver care as employees, and most of all people who receive care should not be punished for that, especially when we're talking about a global pandemic that nobody could have really predicted and prepared for in many ways. So a reform that talks about care workers as skilled professionals, recognize them as such, provides them with support to have a development in their careers, different career pathways. Right now, unfortunately, in social care, we only really have rules into admin promotions, and many care workers would like to continue working in face-to-face care delivery, but then they remain on the same pay with the same title for 20 years plus. And that seems incredibly unfair and definitely a lack of recognition of their professional status, their knowledge and their experience. What's been mentioned about PAs is very interesting, because for many people, in my experience, conversations with a lot of people, especially adults of working age with physical disabilities, personal assistants are a great way for them to get what they need in the way that they really want it. But the lack of regulation around it, lack of support. PAs were not able to access any PPE last year. It was completely out of their reach because there is no system that gives them access. The same issues around training, etc. It's very difficult, but for many people, both on the worker and on the person employing side, this kind of thing works, and reform should, if it goes ahead, if it happens, should include a variety of roles in social care and a variety of settings, because there isn't one answer to all of the problems that will help everybody. The system is way too fragmented, and we have people with so many different needs and many different types of delivering care. But there are definitely basics, like recognizing care workers as skilled professionals, like supporting their development, like making sure that the way you fund care or you pay for care includes paying for somebody's training. That should be available across to everybody working in social care. And then that has been an issue for a long time. The best example of it is really the care certificate that was supposed to be the qualification that puts everybody on the same level, but unfortunately it's never been accredited. Many workers in social care experiencing having to do it 2 or 3 times. Many providers are having to put a lot of money and effort into bulking out the care certificate itself and actually make it of the standard that they would like to train their staff to. And it still is not really transferable because it's not accredited. So a wider reform focused on people who need care, but as much as that on the workforce. And recognition of prejudices that are in place, like the workforce being in majority female, that are putting barriers in place, are absolutely necessary for us to be able to move forward, look after care workers' well-being better. And this is something I always really try to drive as a very strong point. Without a workforce that is paid well and looked after well, we cannot, it's unfair to expect a very good quality care being delivered. You can't do that. So in many ways, for me, it starts with the workforce and the way we look after it.
Thank you. Yes, but just picking up on your idea of the reform, Karolina, you also mentioned that the Care Workers Charity does a lot of work signposting individual organizations about how to, look after the well-being of the workers. Do you also think that is a kind of a top-down approach as well, and that works more effectively sometimes than having a national kind of approach? Because that's what organizations have been doing for decades, right? They've been looking after their staff that way rather than waiting for a reform.
Yeah, well, I think currently the feeling within the sector is that reform isn't necessarily coming soon enough. So everybody within the sector has to do their best to be able to keep things together, because now of all times it really isn't the time for the whole thing to fall apart. Now being when the workforce is under the biggest pressure it has been. So yeah, I think the approach has to come from both sides. You have the top-down approach when you feed through organizations, through managers, and then you have the bottom-up approach that we try to do, and let's say unions or other organizations try to do when you try to contact individuals or message to them directly on social media so they can take up certain initiatives themselves. That's why for us as a charity, the way we work, we do give managers opportunities to refer somebody for a grant or support from us. But the main way we're driving is for care workers to be able to apply themselves, because often there are barriers within organizations, lack of time being usually the main one, that stops people accessing help. So we're just trying to make sure that we approach it from both sides.
Yes. Thank you. Shall I bring Lina or John for their comments? Do you want to add anything from Amy's remarks?
Yeah, I mean, I could. Shall I go next?
Yes,
Yeah,
please.
Just to respond to some of the questions really that you threw out a few minutes ago. Not all of them. First of all, I didn't mention in my presentation that we did a follow-up piece of work which looked at the impact of the COVID epidemic on social care PAs, and Karolina's absolutely right on the money. It had catastrophic effects on their employment. Many people were laid off, and if they were self-employed, they found themselves without income because they weren't entitled to furlough payments. The government was very slow off the mark in providing guidance to PAs. I think it took the first official guidance that emerged from Department of Health and Social Care was in May, so somewhat late from the blocks. Absolutely, I would echo the point that was made about the lack of recognition of PAs when it came to obtaining PPE, and also things like being able to access protected slots in supermarkets when there were, the shortages and the queues earlier in the year. None of that happened for the PAs in my group. I think more generally, I think what we're kind of not really fully addressing is that some of the ideologies around these forms of care. I mean, we've been talking about person-centered care, but within the care industry, personalization and person-centered are used interchangeably. I actually think that we should distinguish between personalization and person-centered. I much prefer the term person-centered because I see personalization as kind of carrying a lot of ideological baggage with it around choice, control, independence. I don't necessarily think that choice, control, and independence are always the best thing. I'm not decrying them completely, but I think there needs to be some kind of resettlement here. The whole notion of independence, the dictionary definition of independence, one of the definitions is a state of aloneness, and that's not a good place for anybody to be. It's much better, I think, if we see ourselves as interdependent. We all have different dependencies depending on our relationship with whoever we're with. And that takes us away from some of the kind of ideologies around personalization towards the alternatives, which are around ethic of care approaches and the work of people like Liz Lloyd and Marion Barnes, that some of you will be familiar with, which I think is a very fruitful field to consider. The last point I'd make in relation to personal assistance is that that there is an absence of regulation and organisation amongst PAs. One of the reasons for this, one of the reasons it's been difficult for PAs to organise, it's not just a question of being neglected by unions or by the government, although that has been a problem. I think there is also a degree of resistance from employers to some of this happening. There were concerns, for example, expressed in some of the interviews I did from employers about people, if they were allowed to network with other people, whether they'd actually be gossiping about personal information. I actually think that the PAs I spoke to would behave in a very professional way. There was also a sense in which there was a great reluctance among some employers to allow people to have independent training. They wanted their workers to do the things in the way that they wanted them to be done, rather than necessarily in the prescribed way. And sometimes that put both PA and employer at risk. For example, giving injections. Sometimes the employer would say, "Do it this way," and the PA would say, "I haven't had any training," and the employer would say, "Well, it doesn't really matter, just do it like I showed you." So all that kind of stuff going on. So that there's a degree of reluctance also, and from the employer's perspective, anything that takes control away from the employer is viewed with suspicion, and that goes all the way to disclosure and barring checks. There's a degree of hostility among some sections of the disabled community, if I can generalise, towards having compulsory DBS checks or any form of regulation or inspection. And I think that's a significant obstacle. That's it.
Mm-hmm. Thank you. Lina, would you like to?
Yeah, I have to say, listening to your presentations and this discussion, that it's really interesting to think about how different the situation is in the Nordic countries in comparison to the UK. Because when I was listening to Karolina, I was thinking that this kind of care workers charity is an idea that I've never met, or I've never heard of such a thing, because as I told it, in the Nordic countries, care workers and these care aides and home care workers, they are highly unionized, and they are quite strong unions, and they are even though they feel that they have a low pay, and of course in comparison to many other professions they do, and there are lots of problems which I talked about in my presentations, but still they have strong social rights when it comes to situations like this COVID pandemic, that they have unemployment security, and they are contracted workers who have strong rights in case of something unexpected, like this pandemic situation. So it is very different to look at this from this Nordic perspective, and this is far from a paradise, as I told in my presentations. We have the serious problem of where to find the people to do care work for the increasing amount of older persons and the increasing needs. But still, it's a very, very different situation. Just something maybe regarding what Amy took up. Now I don't know. I maybe missed already or lost most of the thoughts I have. But you talked about this alternative approaches and the co-production and what would be the sort of sustainable ways of providing care. And I'm thinking, or I would like to say that maybe the problem in Finland and in Nordic countries is that the care workers, many of them still remember the time in 15, 20 years ago when they had much more professional autonomy, at least home care workers. They had the sort of more time to do the person-centered care, because it wasn't so strictly time restricted and task-oriented that you just go in, you do the injection, or you take the person to the toilet or whatever, particular tasks. But the care workers were really allocated time with each client, and they could much more use their own sort of professional evaluations of what is needed, and they could be more flexible also. And I think that much of the frustration that the care workers have at the moment is also related to this. And the sort of worrying situation in the Nordic countries is that we have conducted this survey in 2005 and then again 2015, and now I use the most recent data, but there are lots of changes have occurred, and also the living intentions are much more common now were in 2015 compared to 10 years earlier. But especially the home care worker situation in Finland, at least, is much more critical now. So the situation was not so good already in 2005, but to many respects it's much worse in 2015, and that's worrying.
Yes. No, I actually found exactly the same that you just mentioned, Lina, about these emerging models that I looked at. One of the main reasons care workers were moving from this more traditional model to this more community-based or different models is the main reason is because of the time and task pressure that they have. And on these emerging models, they usually have more time to do what they do best. And this autonomy to be the professionals that they are. But I just wanted to we use a very broad framework for well-being in the sustainable care that talks about the material well-being, which is related to the income, the job, housing, that sort of thing. Then we have the subjective well-being, which is what each person attached to their life and how they evaluate that. So more like the work-life balance, if you like. And then we have the relational well-being, which is the relationship with other people, society, their health, social interactions, etc. But I noticed that each one of you touched kind of different elements of this broader framework. But in a way, I feel, particularly here in the UK, that a lot of the relational subjective well-being actually they are suffering because of the material well-being not being attended first. Do you feel that is that's a right perception of mine, or I mean, obviously all of them are related and they all have to be looked after, but in many ways I feel that the financial pressure, particularly here, I mean, the things that Karolina was explaining, I think is quite disturbing, that care workers need to ask for help, for financial help. I mean, it's not on. How do you feel about that in terms of these different aspects of well-being?
I'll go first. As you mentioned, I think, what you said, the idea of co-workers charity being something different you haven't come across. And in the correct, not ideal, in the correct world and situation, the co-workers charity should not have to exist. Because the workforce that is so important would be looked after enough that the charity wouldn't have to be giving grants to people who are working full-time very often, beyond full-time hours of, let's say, 40 hours a week, quite often as well, that have to worry about putting food on the table and paying for electricity. That really is, like you said, Karla, not on at all. I agree with your perception that other parts of the well-being are hugely undermined and damaged by financial issues, economic status of care workers, of the fact that they have to worry month to month, many week to week, about whether they're going to get enough pay. And at the Care Workers Charity, we do understand that 0 hours contracts for some care workers are the right contract to be on, especially for working age and mothers with small children, or the other caring duties where they get the flexibility from a contract like this. But unfortunately, these contracts are very often one-sided and exploited on the side of the employer and not giving enough benefits to the employee, where care workers are finding themselves worried whether they'll have enough hours of work the following week. That is particularly difficult in home care and for PAs, where if somebody they're working with either changes location, passes away, ends up in hospital, overnight you can lose 20 hours of work a week and that income, and you're not entitled to any benefits, any support in place of that. Like it's been mentioned around PAs, when we were looking at people not having enough hours before COVID to then be put on furlough, having difficulties accessing other financial support as well. So yes, we definitely need to talk about respect and recognition for the workforce as a very important thing in professionalization of the workforce, but it already needs to start with proper remuneration for the work that care workers do. The fact that we're still looking at majority of care workers earning around the minimum wage, some of them still under minimum wage when you take into consideration travel time, etc. That latest sleep-in ruling was that you are only really working when you're awake. It doesn't matter that you're not in your place you can't go home, and you have to be there, and you have to get up at a moment's notice. again shows complete lack of understanding, respect for the role. And it's heartbreaking that there are still some care workers out there doing 12-hour sleeping shifts for 30, 40, 50 pounds. We have to pay care workers more so they can feel better and look after other people better. And that really is the basic need that we have to get to the point of delivering before we can really start talking about anything else.
Does anyone have any questions they want to ask presenters? Or Amy, you had a lot of points. I mean, is there anything that you still want to ask?
I mean, thank you for those comments, everyone. And yeah, sorry that I have bombarded you with quite so many things. I suppose perhaps we could come back to this point about what's going to remain of the changes from the pandemic. Is there anything to kind of, has people have learned within or beyond the sector that you think can be sustained in a positive way? Or if we're thinking about kind of form that care services will take, whether that's different settings or models of decision making, kind of that could have implications for care worker well-being.
Thought many times that if there is something positive and something I hope that we have learned and we will now really put in our minds and remember always, is that now it has come so much to everyone's knowledge that we are social and social human, that human beings are social, and we need also social and emotional support, and we need relations with other people, and we need other people, and also social and emotional needs are related to care. That it is not just enough to take care of people in the sense that we keep them alive, that we give them food and that they are safe and not leave them outside on the street, but also the social and emotional side of care needs have really come forth. And I think that this is also related to the well-being of care workers.
Just, shall I go next? I mean, really, a quick comment for Lina. Really, I was in Helsinki at a conference a few years ago, talking about personal budgets, and what worried me a little bit about what was happening in Finland at the time is that you seem to be in Finland, the government's policies seem to be heading in the direction of what's been happening in the UK over the last decade or so, which we've been talking about today, and is creating quite a few problems, as we've been discussing. But generally, I mean, in response to the more general point, I think what we need to do is to move away from this concept of or address ourselves to the responsibilization of people with care needs. On the one hand, it's seen as enabling people to be more independent and giving them choice and control. I mean, those are the mantra words. But at the same time, it's actually transferring risk, sometimes from very vulnerable people. Transferring that risk away from the state and local government onto private individuals, and that can create all kinds of problems, as we know. The returning again very quickly to what would be useful in the post-pandemic era. I think I've got a shopping list of four things. One is proper information, from trustworthy sources. The second is PPE. I think it was absolutely scandalous that that there were so many there was so much in the way of shortages facing not just PAs but the care industry as a whole. Training. There does need to be proper training of care staff to ensure that people are working to a professional standard. and funding, not just as a precondition for professionalisation, as has been said, but also if people need to self-isolate, so that they don't have a choice between continuing to work and put other people at risk or starving.
Yes, that's great. Actually, Amy, going back to your point, what kind of models you asked earlier, from my research, one type of model that was quicker to respond to the pandemic and work best in that way was self-organizing teams. I found that they didn't necessarily wait for regulations to come up. They kind of acted as the care workers and the care recipients perceived that what they wanted much quicker than than other models. That was just anecdotal, but is what I perceived anyway for that kind of model. Okay, so yes.
Sorry, in terms of models, I just wanted to add that it definitely seems that during COVID we had big growth around home care and then retirement villages models moving a bit away from care homes in a way that's due to very unhelpful media representations on help of care homes and blame game that happened in the last few months where people haven't really understood the difficult situations that care homes were put in. But I think there's definitely more support now and understanding of how care can be delivered well in people's homes, and also potentially moving in a little bit earlier in life into a retirement type of setting, and then slowly introducing more and more care into it. Around things that hopefully we'll take from the pandemic, I would say number one thing is digitization. A lot of settings had to introduce that very, very quickly. And I think it's helped a lot of services keep afloat on top of certain things. And it's been a long coming for the sector. And the other thing is, I hope that the public will remember the huge work and pressure on social care. And that will be easier for us now to educate people, to get more support, for the society to rally behind the social care as they do behind the NHS, and understand that one cannot exist without the other. And from all of that, for the government to finally run with a proper reform that isn't health-centric, that isn't only there to support health, where social care isn't perceived as this additional service to support the NHS, but as a service on its own. That's very important.
Okay, well, we can talk about this for hours, I guess, but we came to an end of our session, and I'd like to thank you all for joining today, and from all over the world and different parts of the country. I hope you all got some insights about it, and I hope to keep in touch as well. And thank you very much, and I'll see you guys very soon, hopefully in person.